Hello, I'm Dr. Margie Neidecker, and I'm here with Dr. Carolyn Schubert, and we are interviewing today Tina Latimer for our DNP Quality Improvement course. Tina is the Associate Executive Director of Quality and Patient Safety for the Ohio State University Health System, and she has administrative oversight for clinical quality, patient safety, physician performance evaluation, infection prevention, case management, and social work. So that's a huge scope of areas and responsibilities. Her expertise is in clinical performance improvement initiatives, benchmarking, outcomes monitoring, and value analysis processes for improving the delivery of safe, effective, patient-centered care. Tina has over 15 years of intensive care experience, is that right? Both pediatric and adult?
I do.
Wow. And so is a registered nurse. And I do want to mention you have both your bachelor's in nursing and a management and health care administration and management here from the Ohio State University. Is that right? So we're glad to have another Buckeye executive, nurse executive with us here. So Tina, I thought I'd start by asking you about your role as the Associate Executive Director of Quality Improvement. So what does that entail? What are you responsible for in this leadership role?
Well, we're responsible for several things. We're responsible for setting the direction of the program, the strategic direction. We're responsible for the training of quality and PI to front loads. We're responsible for monitoring all the outcomes of an area to know how the care is delivered, and we're responsible to work with the staff to ensure there's a bottom-up way to identify issues.
So how large is your staff? Do you have any idea? Have you counted them?
Yes, I have, actually, not very, actually. We have, in most places, we have both a centralized model for quality and safety, and then we have decentralized, because it can't be just quality that owns it. You know, the frontline places have to own and want to own their own quality.
Right.
So we have a staff across the health system, all of our, of about 50 people. Right, we have a decentralized staff then of probably about another 50.
Okay, but that's still a large team, right, overseeing quality. I mean, it's maybe small compared to the size of the health system, but it takes a lot of people.
Right, and if you think about the health system, there's multiple hospitals. That includes all the physician performance reviews, and that also includes our ambulatory sites. Right, so there's 120 of those, right? So if you think about the scope of 5 or 6 hospitals, you know, whichever you would call in, and the ambulatory, and then the physician practice for quality, it's not.
It doesn't, maybe sometimes doesn't seem like
right,
a large team.
Right.
You're covering
100, right.
Yeah.
So our SICU staff is over 200, just as, you know.
Yeah, amazing.
So
yeah.
not that big.
So you mentioned that you have oversight of physician performance evaluation. So what does that entail? What does that mean?
So it's a report card, you know, on how they do. So in order to understand how physicians perform and make sure they're adhering to standards of care and that their outcomes are of a high quality nature, every physician has a report card with certain metrics. And that might change a little bit if you're a surgeon versus an internal medicine, what your metrics may be, but certain ones there's standard for each. So you have a core set of metrics, and we monitor those every month. We report those and share those then with the head. And so then if you see a blip, you know, of maybe somebody not having the best performance or best outcomes, you can intervene. So we're also responsible for facilitating when we see an area that's not performing to where we should, whether it be a physician or a hospital area. If they're not performing to where we would expect them to, then we go in as a team. We send a SWAT team to help them.
And so this is for physician performance evaluation. Right. Nursing quality is another arena, right? Can you explain? So nursing does not fall under the same umbrella.
They don't. They have it in a reporting structure. They report up through the nursing leadership structure. However, we make sure they have to align with the hospital structure, and we have to show that we're aligning in our goals, our strategies, and our method. So nursing has a peer review performance, you would call it, process. It's called for licensed practitioners.
Mhm.
So whether you're an NP, a PA, with certain privileges, or a nurse who has certain privileges to do certain things, your performance is tracked,
Okay, interesting.
right?
Yeah.
And then if there's a blip in that, they would have a process of a peer review to, is it educational? Is it informational? You know, what is, the first approach is how do we help this person perform at standard?
So I want to find out, you're in this leadership role, but obviously you didn't start here.
No, I didn't.
You began as a critical care nurse, and you received advanced training in healthcare management, your master's in healthcare management. But how did you, what is your background, or what was your career path to get to this role?
So, not what it would have to be today, let me say that, right? So, I have been in the quality department for 15 years. And so when I started there, it was more in the role of the business end of utilization of clinical resources. So how do we use our clinical resources, and are we using them in the most effective way, cost beneficial? So let me just make it real concrete. Sequential TED hose, devices, pneumatic devices.
Mm-hmm.
They came in different shapes and sizes. One was more expensive than the other. How do we use those? And is that based on evidence? And could we still give a high quality but not be so costly? And so that's how I actually started in quality, right? I had honestly no desire to go to this other side of reviewing other people, but that's how I became accustomed to it. I will tell you, I was the first nurse to work in the hospital quality department at Ohio State, ever.
So you were a trailblazer in
I
that
don't know.
regard.
I don't know how I ended, right? But upon completing my graduate degree, which was more in healthcare management, I wanted something on the business side, so I started through that kind of clinical resource. But it was with this other side of hospital quality and performance and patient outcomes, and I don't know, just by nature of liking that and sitting in that department, I started to work on more of those projects. And I don't know, about 10 years ago, I think it was, I took a leadership role there.
So now, who's on your team? What type of disciplines do you have on the QI department?
Yeah, so we have a mixture. We have about 50% are nurses now. Are not all, you don't have to be, but it's helpful in some to have a strong clinical background. And a nurse that's had a strong clinical background, to understand. So we have about 50% nurses that help drive the improvements. There are what we would call facilitators that often drive the teams, right? So there's nurses on that end that are out working with the teams that really understand the clinical arena and can establish relationships with all the players, understand what a pharmacist does and physician, Then we have a team of data folks, because you can't improve what you don't measure. So we have a pretty huge team of data folks that pull the data out. They go with our teams, so they're part of it to understand it. So we have some folks that like MHA, MPH type backgrounds, those, add to it. And then we have a fairly large group of nurses that do data abstraction. So all this reporting you have to do, it doesn't just happen. Somebody has to go in and look at a record, even in an electronic record, you have to go in and look, because there's inclusion criteria, exclusion criteria, big manuals to follow, and so we hire a fair amount of nurses for that. So it's nurses, data folks, people with MPH, MHA kind of backgrounds. It's people that now there's actually training in quality. There's operational excellence, right? There's the MBOE program through the college, which now has a healthcare track. There's people that get Black Belt Six Sigma in PI processes. That used to be just for manufacturing. So there's now there's type of degrees in healthcare. So it can be that type of background as well.
Yeah, and you're probably aware this is a QI course and a DNP program.
Right.
So in graduate nursing training, it's now required to
That's great.
also include quality
Right.
improvement.
Because I think in the past, again, when I came to it I had no quality training. I had zero, right? But now there's all kind of curriculum out there, and I would tell you today, if you wanted to go to quality as a nurse, it would be beneficial to have those, whether it be through a course. Institute for Healthcare Improvement has an IHI open school that people can go online, and if you're a student, it's free. You can do it for free.
I think many of the students who are watching now have visited that
Yes.
website a few
Yes.
times during this course.
Right, and I would say we recommend all of our staff do that, whether so they don't come with the quality, that is a core. We required, the physicians now required as their physician training program with the College of Medicine to complete the IHI courses, requirement of their curriculum, because you actually get a certificate when you pass the tests. So it's a good resource. So there's a lot more out there now than there used to be of how to end up in that path. Yeah.
Great. Carolyn, do you want to ask a few questions?
The next section that we're going to deal with is the strengths, the barriers, the facilitators within your organization that are involved in the process of QI. But before we go there, I wanted to springboard off of a comment that you made, or a content piece of Margie's interview, and that is peer review. Because I think peer review for professionals is a challenge, and there's a lot in the literature about how difficult that is. And how do you get involved in that piece of it in terms of the nurses and the physicians doing peer review and the learning how to do so? Is there any kind of education of the staff for how to do it, why it's important, and then any kind of pushback because of it? Because, honestly, a lot of nurses that I'm certainly a nurse, and I know that it's uncomfortable sometimes to give feedback honestly and objectively when this is a colleague or coworker.
So there's a couple things that go on. I think there are peer review councils. Right, so they're clearly educated and trained of how to do that. I will tell you that the peer review processes for the physicians are more advanced and developed than we are for nursing. One, it was an earlier requirement, right? I mean, just by. Two, it's a little easier to track by an attending physician or a procedural physician. It's not as easy to track by a nurse, right? It's often a self-reported system. They track certain things. So across the nation, we've actually looked at this nationally with other groups of how are they doing this for nursing and that. And so it's not like Ohio State's, it's really a challenge, and it's becoming more solidified and more a formal process with more training and expectations, especially as you get out into the NP roles with some of them doing procedural type things. So we try to approach it, we would tell you we try to have what they call a just culture. I don't know if you've heard any of this.
Yes.
Which is a balance of not blaming a person for a system issue with accountability for your own performance. So a system, a healthcare can put all the processes in place, but we as humans are good about going around them, right?
Yes.
Finding the easy go around.
Mm-hmm.
So if a practitioner, be it a nurse or a physician, there's policies in place and you opt out to follow those, you will be held accountable. So a just culture means you get a fair trial, but if you're running the red light, not stopping, going around, when you know that that's what you should be doing, you will be held accountable for that. So it used to be called, they thought it should be no blame culture. Well, that's not right. It's somewhere in between. So it's called a just culture of where that gets mixed of a system issue versus a personal accountability issue. So I think there's a lot of, they call it normal deviance, learned deviance. Oh, you don't really need to do that, skip that step. Oh, you really don't need to do, right? As we as nurses, I look back at my own practices and my own profession and say to myself, I could have been so much better if I had known that, right? If I had done that. I would tell the nurses coming out today, follow those policies. They're there for a reason. Don't listen to the nurse who's been there who tells you, I'll just skip that and go around, right? You can learn a normal deviance, which maybe 98% of the time is okay. It only takes the ones to not be all right. So I think people tend to think those policies and procedures are just something written on paper and steps not needed, but there's a lot of thought about why those are. So that answers your question.
Yes, thank you very much for that insight. So if we think about the organization that you're working within, which is huge compared to many other organizations, would you say that there are specific, what facilitates the process of QI based on your organization compared to maybe a smaller organization that doesn't include multiple hospitals, 120 satellite clinics and that sort of a thing? And along with that, what are the facilitators and barriers when you're talking about the system that you're in compared to maybe another system?
I think a couple things. I think if I would look at it is, we talked a little bit about there's a centralized quality department, and then we have a decentralized, which means it's out in the departments. So it's that relationship and that knowledge that that department, that unit, owns their performance and their quality. The quality department doesn't, right? They have to own it. Now, with that being said, where we're lucky as being a large system and have a lot of resources is we're data rich. We can give them data to show them performance so they know where to improve. Where smaller hospitals just don't have that. I think also we use our students, we have a trifold mission: academics, research, and patient care. And we use a lot of our students in our projects and to help. We have to get pretty, so we have a lot of resources at our hands that smaller places don't have.
Absolutely.
We clearly have a lot more to cover
Right.
than other places don't have. But we're fortunate to be aligned. And when I look across the nation at some of our folks who even are academic medical centers, their hospitals are not physically placed within the university, like on the same physical
True.
location,
Yes. that's
right?
a
They're
good
off.
point.
So
Yes.
here we are, and we can get students because they can walk to us and work from, right? And we can do that. We can get the students from different programs to come in, and they have great ideas, and they're good workers, and they see things we don't see, and so I think it's both a plus and a minus. Things don't happen as quickly,
Right. Well, that's you're large.
Right,
yes.
we are large. I say it takes a long time to turn that ship
Yes.
versus a little skidoo,
Uh-huh. True.
and so you have to be persistent,
Mhm.
right?
You mentioned that you have data, you have specialists just for interpreting or plotting and interpreting the data. Is that correct?
We do.
Okay.
We have people that query the data and bring it in,
Mhm.
then they can put it in a histogram or a linear graph or a pie chart or a scatter, whichever you want to. Although I will tell you, you need a fundamental knowledge of statistics and central tendency theories to interpret the data. You don't necessarily to know what every, t-test chi-squared is per se, but you better understand pretty clearly how you show data, what those mean, and how you interpret it. So I think that stats background, I tell anyone if they're going to start, you better understand the statistic, just the central tendency things of,
Absolutely.
so to know, was that right to show the data that way? Does that show me what's happening? You
Right.
can show same data 1,000 different ways that can hide a problem or display it. So,
Very good point.
yeah.
If you were to identify who the QI champions in your institution are, or if you were going to look out to the nurses and ask them who they see as the QI champions, do you think they'd be able to identify anyone, or would it be the same person that you would identify? In other words, is the QI culture at your institution well known to all levels and all disciplines?
So well known, I think it's something that over the time we've gotten better with. So QI department used to kind of be behind the scenes, so I would say yes, we're well known. We have an intra-site and an external site. You can get on and look at things. We do rounds, right, on the unit. But I would challenge to say we are not the only experts. The frontline people in their areas are the experts, and we actually have kind of liaisons in each area. In fact, we have a program called the Link Nurses,
Okay.
which link from quality to the front line on certain things. The information, so they're their champions. I would tell you, I would rather have the champion in their department, and I'd be the back end, we'd be the back end resource, right? Because they're, so I think it's a mix, and I think it's continually developing, and I think it's better than it used to be, but I think we still have a ways to go.
Well, I think that's one of the questions, in fact, that I was going to get to eventually, so we can just deal with it
Okay.
now. But one of the issues, again, in the literature is the gap that sometimes exists between the front line
Right.
and the QI champions
Right.
or a department such as yours, where it's at the executive level. So you've just answered that in terms of, you brought up the rounds
Right.
process. So how, can you describe what you do on rounds when you go to a unit?
So we have a formal rounding process where there's a group of a leadership team that rounds. And, but I encourage my folks, actually I require it, that they round, just informally. Just be in the place, just go see them, get to know them, I do it as well. Go sit at the desk, watch, talk, listen, ask questions, just be there, because there's so much to gain. It's easy to sit, get caught behind your desk. I actually we block out time on our calendars, just to go round, right? And I learn more from that rounding, I will tell you, and develop more relationships than from sitting behind that desk and being in meetings talking about it. So we do, I yesterday was in the ED for a few hours, I was up on another place for a few hours, and you can just watch and see see so many things. I think to the staff then it also brings to them that you kind of understand. You don't have to still be a nurse at the bedside practicing to be held credible and reliable, but you better be out there visible.
So
visible.
I think that's so interesting and so important, and the connection is facilitated so much by that. If you were to think about the last few months of rounds that you've completed, what would you say are the biggest issues for nurses or in the practice setting with patients at the bedside? What do you think are some top issues that you've been able to identify?
So I think there's a couple we see. Staffing is forefront in their minds. I don't care. We've done more surveys than I've ever, right? I don't care who you ask or when you ask, nobody feels like they're staffed well enough.
Right.
Is that true or not? I don't know, right? I think what people tend to think about is those out of times when you have a really high level of staff or patients compared to your, those isolated, because I know we've looked benchmarking wise at just like our hospital, on number wise, we look staffed actually very well, becoming, at the top percentiles. But if you ask our folks, they'll tell you not, right? Those absolute numbers. So what's happening there, right? What's going on? If you sit in that, you'll start to see, I would tell you just from when I was a bedside nurse. So the electronic medical record, as great as it is, right, for many things, is more time consuming than our old paper records, right? So that's one. It's often not right there for them. So they've got to go take care of the patient and then do this documentation and away from the patient and then remember it. So now what they're doing, some of them, is still writing it down on scratches of paper. So I think the timing it's take, and then the reason, the external requirements for what you have to document now are well beyond what any of us would have had to face years ago. They're extensive, insurmountable sometimes, the detail you have to document for these reporting requirements at the national level. And so what are you supposed to do? Take care of the patient and get great? And so I think the rub is somewhere in there, where as much as technology is helping us, it's not quite nimble enough. When they get it where we can talk into it as we're walking down the hallway, might be, or you can talk while you're taking care of the patient, or but it's an interesting phenomenon when I watch what goes on there.
It sounds like it's really rich in information
It
that you
is.
can gather very casually and really kind of get your finger on the pulse of what's happening.
So I think they would tell us. I know they tell us we don't have enough staff. We need more staff. Is what they tell us as a safety concern or a quality concern, and that they have to document too many things, and that interferes in their mind in actually delivering patient care. They feel like the balance is, it takes me longer to document than I'm able to spend with the patients. Right. And I think the model of nursing has changed. Right? There's a lot more aides.
Yes.
and extenders.
Mhm.
And so how do you communicate between the teams? If you, right? So how does, if you go in there, and I was watching the one, and the aide, we would call them PCAs,
Right.
patient care assistants.
Yes.
How do the aides go in there and they take the vitals? Think about the vitals, right? The most important, they take the vitals,
Right.
they do the intake and output, and they do a lot of that hourly thing that tells you if there's a change. Well, if they're taking it, and then they're not able to put it in the computer system, right? And
Mhm.
there was a change there,
Mhm.
and how does the nurse know that? She might not know that, or he might not know that for hours later, till they put it in the system, or somebody tells them,
Right.
right? So there's a, before, it would be the nurse that did,
That's true.
right? And I keep saying, well, we gave away the vitals, they're the vital sign. I'm still missing that concept, right? They are the sign of
Mhm.
what's going on. Now, the nursing still does the overall assessment and still
Right.
gives the meds
Mhm.
and that piece. But I have to wonder, as I watch the system, and, you know, because I asked him, well, now you wrote that down on a piece of paper. When will you tell the nurse that? When will you put that in the chart? When would that ever be noticed? Because we've had some situations when they will look back, that set of vitals taken by an aide should have been a red flag, but they weren't entered into the system for several hours later,
Yes.
right? So
That is true.
it's a
It's a system.
right. It's a system
challenge.
issue, right?
It's a system challenge, and I guess when we talk about
A practitioner,
organizational
right.
structure, it's a system challenge. And along with that, you brought up just culture a little bit ago. If we're talking about a culture of quality and safety, have you, as a department, had to wrestle with any challenges in that degree, where you sense that the culture wasn't where you wanted it to be in terms of holding up quality and safety to the degree that you thought that it needed to be, and trying any strategies for that? Can you share any thoughts about whether you've been there and done that at all?
Well, we do a lot around our culture of safety, and culture's a journey. It is not an overnight thing, you know, and we still have ways to go there. I would say everyone does, but I would say this, at least at Ohio State, in our high-risk procedural areas, so procedures are done, heart, cath, EP, you know, interventional radiology is now a huge high-risk procedural area, the ORs. We had a culture of people seeing things but not wanting to say anything, right? For one of two reasons. Either they were not feeling empowered to say anything, so the physician in the room was intimidating, or they felt they had to move so quickly, it was about efficiency and getting people through, you know, so there was a different, but they did not feel empowered to say, hey, whoa, time out, like missing the sponge, you know, doing, I mean, you know, so we did a huge undertaking of what they would call crew resource management. I don't know if you're familiar with that,
Yes.
from the
Uh-huh.
aviation industry,
Yes.
right?
Yes.
Concepts of the leader in the room, the physician mostly, saying, hey, you're the team, I want you to raise your hand or call me if you say anything, I'm counting on you to let me know. And we've done a lot with that. We've been on that journey about 5 years, and we have seen significant attitude changes, but more exciting, we've seen a reduced in the events that were happening in those areas.
Right.
We used to have at least one event a month somewhere in our system related to somebody being afraid to speak up. It's like seeing the plane go down and not going, whoa, you know?
Mhm.
And we are now, in the one area, almost 2 years with no event.
Oh my goodness.
Right,
That's impressive.
right? We are having all of our ICUs being years without a central line infection.
That's great.
For following the safety steps, right? So it is a thing, they need data, they need information, the checklist manifesto, if you're not, right? We
Right.
live by that, because
Mhm.
if you think about it, how are we expected to all keep that in our heads, right? But we as healthcare professionals tend to think we're really smart, right?
Of course.
And that we should be able to keep it in our head. And even if you go to like physician training surgeons, they're trained to keep, they're supposed to be, you know, but in reality, nobody can keep all that in, and especially in an emergency situation,
Mhm.
right?
Absolutely.
You might airway this, that, has it been 5 minutes since I gave this, has it been, right, have we done this, but all that matters in outcome. right, in the patient. We know if you get defibrillated and get that first dose, in a couple minutes of your heart, chances are you'll pull through versus if you don't, you know.
Right.
So from that end, we've made great strides.
And you said that's a 5-year initiative that's been going on?
Well, we've been doing it for 5 years.
I know that I have had students in the Ross who I have been visiting doing clinical in the Ross, and across every computer screen is crew resource management
Right.
and the key principles behind that approach to collaboration and communication and teamwork. Is that throughout the university hospitals or just in the Ross?
No, it's throughout.
Throughout, okay.
So we started, and we, being that you can't do it all at once, right? We did like a priority matrix of where we started in the ORs and we worked through.
Okay.
And then we went to like the VIR, interventional radiology areas, right? And then we went to like bronch and endoscopy, and we went to the cath lab. You know, we went to, and right now we're rounding out the ICUs.
That's great.
Yeah.
So that's a big undertaking. Would you, what other initiatives or what major projects are you involved in right now? What's the focus of quality improvement at the hospital right now?
So we break it into buckets. There's not one focus, you know, there's multitude, and we have a quality and safety. So in our buckets of across the health system, there is a body of people, top level people, frontline people that sit on this oversight committee to say what are our what are our emphasis for this year, what are our key areas, and there's areas for quality and safety and customer service, right? And there's areas for throughput, efficiency, you know, so there's different areas. In the quality area, we have a quality and safety scorecard, so we report events. So transparency is a big culture change, right? How you share data, how you show data, what data you show. And what most folks don't know is that is driven by the state. So every state's different. So if you read about New York or Pennsylvania, they're a mandatory reporting state. They report it all. It's all up for everybody in the whole area to see. Ohio's not. Ohio's a very conservative state, right? And Ohio State, being a public university, is even more conservative in what and how we report. And we've been pushing the envelope there, and each year we add, but internally, you know, that culture of transparency, because if they don't know, you can't fix what you don't know, right? You just can't fix. But I would say our areas of focus, back to that, our goals, are very much around what we would call, we know as preventable harm, right? Things that shouldn't happen if you do certain things. Very much around infection prevention, right? If you have a central line, we know that if that gets infected, your chance of mortality is fairly high. And at the minimum, your hospital stay is going to be doubled and twice as, you know, if you get a bloodstream infection from a central line. So there's what they call bundles, if you've not heard of them.
Yes.
But here's the 5 steps you should do when you put in a central line. You should wash your hands, you should gown and drape, you should use sterile, wear a mask. And those were, I call them, normal deviants people got away from. Well, I'm not going to put on the mask, who cares, right? I'm not going to, if I put on gloves, I don't need to wash my hands. Yes, you do. So we have the bundle, and we have the monitoring, and we review every infection, and we report them, and we number them, and you get accounted for, right, a
Yes.
unit or that.
Right.
And so we know through those metrics we've gone to 0 for years. So infection metrics are a big focus, right? Preventable harm is what I would say. Procedures on the wrong side, we shouldn't be doing those, right?
Right.
Procedures on the wrong patient. You take down this Mr. Smith, it should have been that, right? These are the things we focus on in the preventable, what we call preventable harm.
Okay, excellent.
So
So if you think about the future, what do you think are the biggest challenges to your department, to quality improvement in the future? And do you see nursing, where do you see nursing fitting into the challenges or the champions
Right.
of QI?
So I think a couple things. So challenges. I think the public reporting of quality indicators at a national level is both the best thing that's ever happened to us and the bane of my daily existence.
Mhm.
You know, it's both the, right?
Yeah.
It's both,
Sure, it
Because-
comes with accountability.
right. And they
which-
now pay for performance. So in what they call the healthcare reform,
Mhm.
the way hospitals get paid has changed. And so what the national CMS does is they take a pool of money away from every hospital across the nation. And based on your quality performance, you earn it back. And better performers get more of that pot,
Right.
and worse performers get less of that pot of money, right? So we at Ohio State have gotten our amount back plus quite a bit. So we're very, but that's gonna start getting tighter and tighter. So 10 years ago, there were 10 metrics. There's now 200 we have to report
Wow.
nationally.
Yes.
And so the challenge is, how do you do that with not adding insurmountable cost in staff and
Right.
where's the breaking point?
Mhm.
Those metrics are not decided by government agencies, so let me be clear about that.
Mhm.
Those are decided by the National Quality Forum,
Okay.
and that is a group of physicians and practitioners. So it's, people say, well, what's CMS doing, they don't know anything, that's the government. No. This is healthcare people making, so our goal this past was to get Dr. Moffat Bruce, our physician lead, on some of those forums, to have our voice, and she is.
Oh, excellent.
Right, because we need to make sure that they're the right type of things, and they're not so absurd in trying to collect them or measure them that they are meaningless. So, to that point, I think the healthcare quality is growing in leaps and bounds
Right.
as a profession. If I would tell you, looking at nursing and being a nurse, and I look at where we are with physician education, I think we're farther there. Not necessarily in the graduate, but in our, and maybe I'm not familiar, but I'd ask us, what are we doing in our undergraduate nursing to help our nurses come out? This is part of their training. Because when we go talk to them, they're like, one more thing I have to know. And I'm like, one more thing you have to know. This is what you should be doing. I'm not
Right.
adding steps. You should be doing this.
Mhm.
But somewhere they're separating out mentally that this quality and safety is just one more thing, instead of this is the thing, part of my practice.
This is the foundation. of
Right,
the
I don't think they're
practice.
tying and I might be wrong, I don't know if they're tying I have all these steps to do to put in a Foley catheter, and there's a reason behind those.
Right.
Right,
Absolutely.
in that, and then when I really go out and do it, right?
Absolutely.
So I don't know if
agree.
that's still but I know just in the last few years, we're heavily in the physician curriculum.
Yes.
We're over there teaching it, we're over there working with them, they have to do certain things with us, we hire medical students in the summer, they all get a project, a certain amount, it's a little more formalized. And there might be opportunity with nursing to do something a little more with that.
Yeah, those are good points. We know that we have QI threaded throughout every level of our
Right.
curriculum, but it's still going to be the transfer of the theory piece into
Right.
practice. That's always going to be the
It
challenge
is.
for any discipline.
You're right.
Really, is to get both pieces and parts of that
Right.
to mesh. So if you could change one thing about the system the way it is now, or just quality improvement efforts in general, is there any one thing that you think you would change or at the system level related to quality and safety to facilitate the process or make for better outcomes? You've covered a lot of
Yeah, I don't know if
great
I could say there
ideas.
was one thing. I think just to realize that you constantly have to work at it. It's not something you fix and walk away. We know this. We know if we go into an area and fix it, right? And we leave. If we don't if that local group doesn't have a thing for sustainability,
Right.
we will be back there. Right, so if I could change anything, it would be, do I only have to come here once? And I'd look back 5 years later, and it's still there. So, why does it change?
Right.
And I would argue it's the players change. And we're so person dependent, right? We taught that leader, we taught that nurse manager, we taught that person, and maybe it was their mantra, but the new one, we're not quite hardwired completely, so that it's not opting out. You can't opt out.
Right.
You can't opt out. We are now, though, at Ohio State, performance for quality and safety metrics are part of the pay system in your evaluation. And they're at the pay of the senior leadership. So part of their annual pay, their annual performance pay at our CEO level is based on the healthcare or quality outcomes.
So that's the executive level?
Yes.
There are so there's financial incentives at the executive level to,
And sticks, if you don't do it right, you don't get the outcomes.
so it
And
has
that's
to be
huge.
outcome related, it's
Correct.
outcome associated.
Right.
That's
Yes,
really
so it's interesting, some places don't have that.
Right.
We are fortunate, our current leadership at the executive level is passionate about quality and safety. And it is on there's different buckets for their performance payment.
So is there a way that you've seen work in terms of sustainability? Because we are always going to have turnover of staff and champions and.
So, yeah, I think I'd like to say we're all so altruistic enough that we do it on our own. But the reality is, tie it to the performance, right, to pay. Honestly, I hate to say we're driven, but I spent some time talking with the University of Michigan, right, our competitors on the, right?
Absolutely.
On the sports arena.
Yes.
So the University of Michigan on their is phenomenal. They perform well all the time, every year, after year, in, out again. You know, you don't see any variation there. They're a big health system.
Mm-hmm.
So I spent a fair amount of time talking to them. What are you doing? How are you getting that?
Yeah.
Right?
Right.
And they said to me, and it may have changed over, but at that point, they said we are driven because all of our patients are coming from the three big automotive, the employer, right? Right. All of our payers, so they have a heavy commercial payer population, are coming. And if we don't perform that way, they don't pay us well, right?
Mm-hmm.
And so down to their physician level, right, it's always based on pay. So I think the way you hardwire it is you make it part of somebody's report every year,
Do you
their
think that would
evaluation.
work with nursing?
Oh,
Do you
yeah.
think that would work with nursing? Although
I
it's
do.
not a well-known strategy that's
You'd have to
being
pick the
used
right
in
ones.
nursing.
You'd have to pick the right ones. You can't hold nursing accountable for things that have no control over.
Right.
But you could surely hold them accountable for falls.
Well, the nursing
Pressure
sensitive
also,
indicators,
right?
we talk about
Absolutely.
those. Absolutely.
Absolutely you could.
Okay.
Now, I'm not sure at Ohio State where they're unionized and they get a pay, but right? But
Mhm.
in concept, you can even within the union, you could work that. We work with our managed healthcare payers, our largest payers, Anthem and Aetna,
Mhm.
to have a value-based system. To say, look, if we perform really well, we want our standard money and then extra on top. And we do fairly well in that, honestly. So you could in nursing within certain places.
Mhm.
And we are starting to do that with our physicians. So all of a sudden the physicians are really very interested. It's a great way to, honestly,
That's a great idea.
it sounds to us who went in healthcare counterintuitive to what our mission of helping people, and, but when it really comes down to it, it drives a lot.
And I think there's increasing evidence to show that, to
Right.
support that. And so, certainly
Right.
I think we're only seeing the tip of the iceberg
Right.
in terms of what it can do.
I
in the
think
future.
states and areas that are heavy managed care contract have been are ahead of us on that, right? But I think we're starting to see it. We're seeing it in our physician contracts, right?
Right.
We're going to see it in some of the nursing probably type of things, at least in the nursing leadership level,
Right.
right? You might not be able to do it at staff nurse level right away,
Mhm.
but you can surely hold your managers responsible
Great
for that.
ideas. Yes.
So,
Well, Tina, thank you. You've covered so much ground with us in a short period of time. We've really been able to delve into the organizational piece of things in terms of the bigger picture and how QI really is a thread, as you said, several times, frontline all the way up to the executive level. It's been so helpful to see and talk about the barriers, the challenges, the facilitators, just how the infrastructure lends itself to achieving quality and safety. Thank you so much
thanks for
being
inviting me.
here and sharing your expertise with us.
I would say our doors are open if you ever want us to, talk to your groups, or if there's any of your students that want to come over and shadow,
We'll be knocking.
right?
Yes.
We would love to work with you in our nursing. We work hand in hand with Jerry Mansfield and Dr. Nash.
Great message
and
to
Dr.
get
Buck.
out there.
So we are happy. We love the having our academic mission.
Thank you so much.
All right, well, thank you.